You're watching Capitol View, Sunday morning talk focused on the political scene in Arkansas.
Welcome back. If you're just joining us, I'm Olivia Walton, filling in for Roby Brock to host a special Mother's Day segment of Capitol View. Today, we're focusing on Arkansas's maternal health crisis. And joining me now are Janet Mann, Deputy Secretary for Programs and State Medicaid Director, and Dr. Sam Greenfield, Chair of the Arkansas Maternal Mortality Review Committee and Professor of Obstetrics and Gynecology at UAMS. Thank you both for joining us.
Thank you for having us.
I am so excited because there seems to be real momentum in the state right now, in large part thanks to Governor Sanders' executive order, which created this maternal health steering committee on which both of you sit on. So that's what I hope we're going to talk about a little bit today. Dr. Greenfield, let's start with you. You're still practicing. You are on the front lines of this. You're seeing patients all the time. Can you help paint a picture of why this is happening? Why are more mothers dying in Arkansas than anywhere else in the United States from complications from childbirth?
Well, one of the things that we know is that we have a sicker state. Many of our patients come in with a host of medical problems that raise their risk of having complications. That's the starting point. But additionally, there's issues with patients taking advantage of access, receiving effective, comprehensive prenatal care and delivery services. So there's an opportunity for education, there's an opportunity to improve outreach and improve care. So it's a number of factors there. And we're in a good position now that we're addressing the problem and having this discussion out in the open.
Yeah. And Janet, when you start talking about maternal health, it seems to just always come back to Medicaid in this state. I mean, more than half of our births in Arkansas are on Medicaid. Medicaid plays such a critical role, and particularly because the private insurers often peg to Medicaid. How can Medicaid ensure that more mothers have access to the care they need?
Actually, we're going to try to tackle that on several different fronts with education and outreach and helping with enrollment. One of the charges in the executive order was to streamline enrollment into Medicaid, but also help with finding additional care elsewhere if Medicaid's not an option. But in addition to that, on the reimbursement side, the charges in the executive order, Medicaid is going to look at the payment model. So historically in Medicaid and private insurance, it's a global payment, which is you only pay once when the baby is delivered. Therefore, we don't have any prenatal data, and so really looking to how we can change that model to help the clinicians across the state to have claims, but also help the moms get in to see the clinicians during the pregnancy.
And for those who might not be that familiar with that global payment model, can you, you explained this to me the other day. Describe why that's so important. It means that right now only the OB is getting any reimbursement and there's no room for other providers?
Well, it's complicated, unfortunately, because it's Medicaid, and so we want to make it uncomplicated. But when a baby is delivered in a hospital, the hospital bills for that day, but then the clinician bills for that delivery. So there's no claims prior to tracking any prenatal visits of when they get pregnant or when they have been successfully seen by different types of clinicians through their pregnancy. So we want to change that model. We want them, as soon as they know they're pregnant, to have an education and awareness campaign to know what to do, when to get in to see a clinician, and to have that successful visit throughout their pregnancy, but then also after birth having some home visiting and options for postpartum visits also. So really changing that landscape so that we can know what's happening at all times of the pregnancy. It's a big challenge. We're going to have to work with all interested parties to make that happen.
Yeah, it's a big challenge, but it's going to be really powerful changing those incentives. So thank you for your leadership. Dr. Greenfield, we are a rural state, you know, and we are never going to have a big hospital and a licensed OB even in every single county. But right now there is nobody licensed to deliver a baby in over 60% of our counties. How do we build out the workforce to ensure that moms are getting the care they need?
So across the state, we have OBs who deliver, family practice physicians who provide OB services, and a small cadre of midwives who provide OB services as well. So there's no doubt that there's a need for increased workforce, and that's going to be a process that's going to take time. If you increase the number of midwives, it will take time to train. If you expand residencies, that will take time to train. But I think it's important that we take advantage of the resources and the tools that we have at our disposal now. We have a number of capacity, a pretty good capacity to provide prenatal care through local health units across the state. That's one thing. And there are there's a need to connect patients with the resources that are available. Things like telehealth have been in place for several years, and we have a host of things that are probably underutilized. So as we're going through this process of expanding workforce, there's also going to be a process to expand and connect patients with the resources that are currently available.
Tell me more about what role you think midwives can play, because I have read that, for example, in Alaska, more rural than Arkansas, midwives play a really critical function and can be can really turn the tide of what's happening with maternal health. Do you feel like midwives are a good option for Arkansas? Is that within reach?
There could be a good option. We certainly would need more, and not only would we need more, we would need more deployed into the places where the need is greatest. And that can be through a process of collaboration with existing hospitals, existing practitioners who provide service. So it's simply not just an increase of number, but there need to be strategies in place to make sure that when that number increases, that they actually end up in places where the need is greatest.
Talk to us a little bit about doulas. That's a word that I think actually means different things to different people. Is there a role for doulas on a birth team? And then, Janet, is that something you would ever consider reimbursing?
Yeah, absolutely. So a doula is a birth attendant who provides emotional support through the process. Now, it's important to understand that they are not medical care providers in the sense of providing services as an OB or as a midwife would, but that emotional support through the prenatal period, through the postpartum period, can go a long way to ensure that the patient has the best experience possible as they provide emotional, physical support during that time. So really important.
And yes, doulas are something that Medicaid is looking at to reimburse. We already reimburse for certified nurse midwives in the state of Arkansas, and then with further looking at different clinicians and different services that we can do, doulas is on top of that list.
What are some of the potential challenges with Medicaid reform here?
So there's always challenges. It's a public benefit, so there's always a challenge of a budget. But we've been fortunate to be funded every 2 years and funded well. I think everyone is interested in the state of Arkansas tackling maternal health, so we actually see that as an opportunity. But there's always a challenge with the bureaucracy of getting things done and passed. So we have a partnership with the federal government, with CMS. They've been supportive, and so we feel like that can be a reduced barrier to get some additional services in line.
That feels so important, because navigating some of these benefits just is, also at a time in your life where you've got so much going on, you've got less bandwidth than ever, it's really complicated. So,
and I think that's something we have to do better at Medicaid and throughout the state, is the education and awareness. What is there? What are the options? How do we make it easier? In person, online, even with telehealth, and even going out to pediatricians, going out to different clinicians, daycares, and other places to make it well known.
Many of us were pushing for 12-month postpartum expansion of Medicaid, but in many ways what the governor announced actually goes beyond that. Can you explain that?
Sure. So when we looked at the program last year, we looked and we did not find a gap in coverage. And what I mean by that is Medicaid covers a higher percentage of income of women coverage for pregnancy, up to 209% of the federal poverty level. And so with then looking at 12-month postpartum, we couldn't identify a gap where someone was not having access to coverage. And so that's one of our charges, is to make sure they have the access to care either through Medicaid or through the marketplace. But we also made the commitment that if we identify a gap, and we need to address that very quickly. So nothing is off the table yet.
And Dr. Greenfield, from your perspective on the front lines, how big of a difference do you think this could make?
I think it's going to be huge. We know that access and utilization of prenatal care, good prenatal care, makes a difference. And when there are resources that are available but underutilized, it's no surprise that we have some of the bad outcomes that we can have. So I think the efforts that will connect the patients with the resources will go a long way, just to ensure that patients are receiving the care that they need.
Yeah, and sometimes you also hear that there are services that exist, but women in Arkansas families don't actually know about them, such as our federally qualified health care centers.
Agree. There's a great opportunity. We have a wealth of resources across the state, and I think even when you get with an informed audience, you begin to realize you know a lot about what you do, but frequently we're not all in the same room having these conversations, so we're at a very unique position where everyone is discussing the issue.
And this is why I'm so optimistic about your committee. Well, don't go away. We will be back in just a moment with more on the Arkansas Maternal Health Steering Committee.
You're watching Capitol View, Sunday morning talk focused on the political scene in Arkansas.
Welcome back to Capitol View. If you're just joining us, I'm Olivia Walton, filling in for Roby Brock to host a special Mother's Day segment of Capitol View. Today we are focusing on Arkansas's maternal health crisis, and joining me again are Janet Mann, Deputy Secretary for Programs and State Medicaid Director, and Dr. Sam Greenfield, Chair of the Arkansas Maternal Mortality Review Committee and Professor of Obstetrics and Gynecology at UAMS. Thank you again for being here. So in March, Governor Sanders signed this executive order, and critically it created this steering committee that both of you serve on with 5 others.
Yes.
We couldn't be more thrilled about it. In many ways, it went above and beyond what we even hoped for. Can you tell us a little bit about what the committee has been charged to do? Dr. Greenfield, let's start with you, and what your role is in it.
So I come to the committee as chair of the Arkansas Maternal Mortality Review Committee, and I lend a clinical lens. I have the opportunity to review unfortunate outcomes, to review maternal deaths, and to bring forth the recommendations that that committee makes. The task force that we are working with will do several things. One, do things to enhance education about resources that are available, improve maternal health care, increase access to quality care, and most importantly, help to coordinate the data between the groups that are involved. Those are the core functions of what we're trying to do.
Mm-hmm. And Janet, what is the timeline now, and what are some of the key components for you?
So, signing the executive order in March, we have approximately 6 months to report out to the governor on recommendations. I know we're down to 4. I'm trying not to think about that part, but we've been busy. We've been meeting internally, the group, but we did have a large stakeholder meeting, Zoom and in person, and so now we are working on subgroups, and the subgroups are focused on the education and the outreach, looking at how the agencies can do better, but also looking at potential public-private partnerships on the awareness throughout the state. Then we are going to also look at clinical improvements, which Dr. Greenfield and his team and other clinicians are serving on. And then there's a large piece of Medicaid access and improvement. So there we will look at eligibility and enrollment. We will look at the payment model, but we will also look at different services to be offered. And then I think the biggest piece is tying it all together with the data and the reporting and the technology. Mm-hmm. How do we get data, how do we use it, and then how do we report on it? And I think those are the big challenges. Mm-hmm. And then another piece that's kind of ad hoc to that is CMS has a transforming maternal health model application coming out that Medicaid will be applying for, or all intents and purposes are to apply. It will be awarded to about approximately 15 states over 10 years. We're real excited. We're hoping.
And what does that mean?
So transforming maternal health. CMS recognizes that the states need to work on this. So they are going to have a 10-year plan, 3 years of implementation, which we are not going to take 3 years. We don't have time for 3 years. So we are going to look at the whole person on the delivery. Mm-hmm. It also has a data piece, and it also has a healthcare workforce development. So that will be an add-on and an additional enhancement, I think, to all the work that the committee is doing. So we're very excited about that.
Interesting. And Dr. Greenfield, part of the order announced that there would be pilots in 5 communities. Can you remind us where the pilots are happening and what is it exactly that they're testing?
So we've selected 5 counties to start a pilot program, and those counties were selected based on information that we have regarding low enrollment in prenatal care and late prenatal care. So those are counties that are definitely in need. Garland, Polk and Phillips, Scott and Crittenden County are the counties. Now we've had our first local stakeholder meeting shortly after our larger meeting a few weeks ago down in Garland County. And it was a fantastic meeting because we brought together people who you wouldn't normally think would be in the same room talking about maternal health. Healthcare providers, hospital executives, healthcare providers who are local to the community, educators, fire department, police department. All of these folks who are trusted within the community have a vested interest in making sure that the community improves. So we're off to a good start.
That's great to hear. And Janet, how will success be measured in those pilots?
I think with seeing an increase in prenatal care and in self-reported data, but then trying to get that new data there, but also the local health units are going to work with the DHS offices, and we're going to look at Medicaid enrollment and Medicaid access and usage.
You've mentioned data a couple times, and that is really critical. That's one of the reasons we commissioned this report from Heartland Forward that showed the investment case for the state, for private philanthropy to actually invest in maternal health, because adverse outcomes from maternal health are costing the state about $2 billion a year. So, and I know that Governor Sanders cares a lot about the data too. If you can show that this makes sense, that this works, that this saves the state money, I'm sure she's going to get behind it. So it's a really important part. What else can you tell us about the role that data is going to play in informing Medicaid's programs?
So during our pre-work or our research in trying to get ready for this, we discovered, working with the health department, that most of the data is self-reported on how much prenatal care is obtained. And so then we went to Medicaid and we saw the births and we saw no data beforehand. So a lot of times Medicaid was finding out about the birth of a baby when the baby was being enrolled in Medicaid. So we quickly identified that there's no data on prenatal in the state of Arkansas. So that's the biggest thing we want to change, is if we can get that prenatal care between the local health units, Medicaid enrollment, and then going to see clinicians, we can really see what is happening and then be able to make sound decisions on additional services, additional needs, what is needed throughout the state.
We are going to have to measure it if we're going to figure out what we're doing.
Yes.
A final thought, please, from both of you on kind of the cultural and social environment down here in Arkansas. When we talk about maternal health, access to contraceptives, sexual health education, those are both important parts of this. You know, they are proven to reduce unwanted pregnancies, and they're integral to maternal health. But we also need to respect people's privacy, cultural norms, and conservative values down here. How do we get this right for Arkansans?
So these are sensitive topics, and they will require difficult conversations. But fortunately, we're having these conversations. They're direct, and as with the pilot programs, we're starting locally in the community, because each community may be a little bit different. And the only way we will know will be to listen to what their concerns are. So we're off to the right track. I would say difficult conversations, but directing them head on.
And I would just add, with those conversations in those pilot counties and things that are being done, that becomes an important feedback component for the education and outreach to appropriately address throughout the state what we can do with contraception.
Yeah. Dr. Greenfield, can you talk just for a moment about the importance of family planning?
So family planning is important. We know that a large percentage of children and pregnancies that come on are not necessarily planned. But once they are there, we are obligated, we have a duty, a moral and otherwise a duty to provide the best care. And when we do our work within the committee, we frequently go upstream. We ask the question, could this death have been prevented? But we always end upstream with, what was the mother's plan? And that is the question. That's the question for that pregnancy, and it should be the question for the other ones going forward. So family planning is a very integral part, and I think that becomes part of the education campaign that we're involved with as well.
Dr. Greenfield, Janet Mann, thank you so much for joining us today, and thank you for your thought leadership on behalf of the entire state.
Thank you for the opportunity.
We'll be back in just a minute with more.